back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I am going to discuss with you about cardiac arrest. It's a very important topic. So, what is cardiac arrest? So, here we can see the cardiac impulse originating from the SA node, activating the atria and ventricles, and you are getting the normal sinus rhythm. So, by definition, cardiac arrest is the sudden cessation of cardiac activity with hemodynamic collapse. The hemodynamic collapse is confirmed by unresponsiveness, apnea, and absence of palpable central pulse. So, here he can see somebody is lying down, unconscious, no breathing. If the carotid pulse is not palpable, you can say the patient is in cardiac arrest. This has to be differentiated from syncope, which is transient loss of consciousness with a spontaneous recovery due to decreased cerebral perfusion and seizure, sometimes stroke and coma. So, main feature which is differentiating is the pulse is present in seizure and syncope, and pulse is absent. Central pulse is absent in cardiac arrest. And sometimes seizure may have aura, and the recovery is spontaneous usually in syncope and seizure. And other details will be discussed in another session. What is the underlying pathology in cardiac arrest? The causes can be of three types. One is ischemic heart disease, second is structural heart disease, third some certain electrical abnormalities in the heart. So we'll come to one by one. First and foremost is ischemic heart disease. Around 85% of cardiac arrest is due to acute myocardial infarction leading on to ventricular fibrillation, the most common rhythm in the initial minutes that produce cardiac arrest. That is primary ventricular fibrillation. Second is car-mediated re-entry VT leading on to VF or deteriorating into VF. So the most important cause, 85%, it is ischemic heart disease. Second is structural heart disease, around 10%. Most important are aortic stenosis, hypertrophic cardiomyopathy, arrhythmogenic ventricular, right ventricular cardiomyopathy, and dilated cardiomyopathy. So these are the structural heart disease, only 10%. Most important is cardiomyopathies. Hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, DCM, and 5% are due to primary electrical abnormalities like long QT syndrome, the Brugada syndrome, sometimes in WPW syndrome, drug-induced arrhythmias, especially Torsades point is whenever a drug that increases the QT interval. Here you can see the QT interval. With the QT interval is prolonged, we can get arrhythmias. Always remember electrolyte abnormalities, potassium and magnesium. So cardiac arrest stems from a catastrophic electrical failure of the heart, not mechanical. So this is something you should remember. So what are the basic arrhythmias? They are divided into two types. One is shockable and other is unshockable. Shockable means they respond to cardioversion. Ventricular fibrillation and pulseless VT are the two important conditions. In asystole, there is no cardiac activity, the line is silent, and pulseless electrical activity. Previously, it was called electromechanical dissociation. So, what is pulseless electrical activity? Any arrhythmia other than ventricular fibrillation, not arrhythmia, any rhythm other than ventricular fibrillation and pulseless VT constitute the pulseless electrical activity. That is, there is a electrical activity is there. Any other rhythm other than VF and VT is there, but there is no pulse. That is what is meant by pulseless electrical activity. So how will you diagnose? The clinical presentation is sudden collapse. Somebody may be talking or lying down, suddenly become unconscious, a sudden collapse. Second, there is unresponsiveness, agonal breathing or apnea may be there. So usually the breathing may take longer time to cease completely than cardiac function and absence of correct pulse. And later with the brain death there can be fixed pupils. So here we can see the four rhythms. The first is this one is the can see this a white complex QRS tachycardia is occurring. It is 190. So this is the ventricular tachycardia. Here this is deteriorating and is developing only some electrical activity is going on. This is the ventricular fibrillation. No discernible electrical activity. No rhythm is there. These two are called the shockable rhythms. So this is the line. There is no electrical activity. This is asystole. Before diagnosing asystole, see that the lead connections are correct. And this is what is called the pulseless electrical activity. That is any rhythm other than VF and pulseless VT. Apparently normal rhythm can occur, but there is no pulse. That is the pulseless electrical activity. As mentioned, these two are non-shockable rhythms and these two are the shockable rhythms. So time to CPR and defibrillation determines survival. So that is whenever there is a cardiac arrest, CPR is very important. Always remember the mnemonic H and T's. H stands for the hypoxia, hypovolemia, hypo and hyperkalemia, hydrogen ion that is acidosis, and hypothermia. T stands for tension pneumothorax, cardiac tamponade, toxins, and thrombosis that is myocardial infarction and pulmonary embolism. So the take-home message is recognize the cardiac arrest early. So the clinical features I have mentioned: start high-quality CPR immediately, defibrillate shockable rhythm. Think the 5 H's and T's. Post-resuscitation care determines long-term survival. The next session will be discussing the CPR and the post-resuscitation care. Hope it was useful to you. Stay tuned. Thank you.